In the past 30 years, I've walked through more than 1,000 hospitals in Africa, Asia, Europe, and the Americas. And I've been lucky to evaluate the performance of about 100,000 hospitals and more than 80 country health systems around the world. What comes into question for me is who really pays for the services that we receive? Why are some health systems performing well? Why are some health systems performing poorly? And I must tell you that when I walked into some of these hospitals, some were really good, excellent. Some in Switzerland, Germany, and parts of the US were top notch. Even in Africa, some in Asia were out of this world. But within the same continents, some were really deplorable. There was a lot of suffering I saw, a lot of wait times, and there was a lot of catastrophic spending. The question around all these experiences was who pays for these services that makes some services excellent, improving annually, while some just keep decreasing in quality? So, my name is Chris Alando. I've spent the last 30 years looking at development financing, particularly health financing across all the continents. In the next 30 minutes, I'm going to tell you what I learned about why a lot of these systems fail or succeed, but also I'm going to tell you, pick up from where we left in 2021 on health insurance and why some insurance systems fail and why some actually tend to succeed. This matters now because we are no longer talking academically. We are now talking about practical issues. Why do some systems fail and others succeed, despite all the knowledge, all the policies we've passed? Number two, we need to acknowledge that aid has fallen drastically. External aid, especially to African and Asian countries, has fallen drastically since 2021. And now in 2025, we had the US aid freeze. And in 2025, a bit later, we had some contractions across most donors, including the Global Fund and others who requested reallocations. So across this continent, ministries of health spent about the first half of 2025 just doing emergency math. We need to find out how fast to protect the poor in such systems. Number one, who should do this protection of the poor? Who should pay for health worker stipends? Who should pay for drug procurement? So, the reality is we need to think about health insurance as the most sustainable way to fund our systems going forward, and not urgently as policymakers like to do or to call it. We say urgently, meaning tomorrow. When you go back to work, when you go back to school, think about health insurance. Health insurance systems in the world are judged first on two tests. The first one is the affordability test. Can a family of median income pay that premium without skipping meals? When someone gets seriously ill, and of course, we all know somebody who's been seriously ill at one time or the other, are the payments that they make out of pocket catastrophic? Meaning, do they lead to poverty? The second way a health insurance system is judged is through what we call the money value for money test. So, for every dollar, shilling, naira that goes into the system, how much of health protection actually comes out? Is there value for money? Is it efficient? Is it economic to take this service? Is it effective? Do you get any results? Is it of a good enough quality? And is it equitable? The architectural choices that determine how a country navigates the tension between efficiency, effectiveness, or value for money on one hand and affordability in the other. That is what we're going to spend the next 30 minutes focusing on. We're going to look at about five systems. I want to take you through the systems in Germany, Switzerland, the US, Turkey, and Rwanda. I've picked this deliberately because they span the entire institutional spectrum, from the highly developed multi fund European systems to the most fragmented private payer system in the world, developed world. So, Otto von Bismarck, if you remember your history, created the first social health insurance system, the modern one, in 1883. So that was about 143 years ago. And it still works. 90% of Germans are covered through about 100 not for profit sickness funds. But the other 10% of Germans are in substitutive private cover, private health insurance cover. How it works matters. Workers in Germany contribute about 14.6% of their wages currently, which is split equally between the employer and the employee. So that money flows into this central pool that we call sickness funds or Gescher Heights funds. And then it gets distributed back to those sickness funds. But this is not distributed in proportion to what each fund collected. No, it gets redistributed based on the actual health profile of each of those sickness funds. So this is actually what makes all those systems work because they have about 100 sickness funds, but they do subsidy, which is about for about half of your Swiss residents. So the state pays at least a subsidy. Now, that subsidy is what makes the Swiss model function in practice. Because without the subsidy, half the country would be uninsured. The Swiss system is not perfect. Out of pocket costs still are some of the highest in OECD, but I can tell you that the Swiss system is great because I've once broken a leg, and within about a week, I was on my feet, great titanium put in it, and I was walking again. So the Swiss have tried to change it through some referendum in June 2024, but the simple architectural elements of mandatory enrollment, the guaranteed issue, the uniform benefits basket, you get everything. Non-profit operation on that basic cover. That risk equalization that Germany and Swiss do, those are the elements that work a lot and make the Swiss system work.